Well, good morning, everyone. Just wanted to thank you for joining us today. We have some information on our slide that hopefully helps answer some questions that people usually have. I'm Christina Clayton, one of the co-directors of the Northwest Mental Health Technology Transfer Center, and welcome to today's webinar, Transgender Mental Health, Co-Conspiratorship. We're so grateful many of you could join us. But first, we'd like to start with our land acknowledgement. The Northwest MHTTC honors the many cultures and lands and people across our region, which currently covers Alaska, Idaho, Oregon, and Washington. And our University of Washington sits on the Duwamish and Coast Salish people's land, past and present, and we honor with gratitude the land and the people who have stewarded this through generations. If you'd like, you can visit this link, and I think that will be put in the chat. Great, thank you. And you can identify the stewards of your land and feel free to type that into the chat. The MHTTC Network is a nationwide network supported by the Substance Abuse and Mental Health Services Administration. Our network includes 10 regional centers, a National American Indian Alaska Native Center, a National Hispanic and Latino Center, and a network coordinating office. And there are also networks similarly structured for addiction and prevention using the same structure. Our Northwest MHTTC covers Region 10, which includes, as I said, Alaska, Idaho, Oregon, and Washington. Now, a little bit more about our Northwest MHTTC. Our goals are essentially, and these are basically what they are for the network, to accelerate the adoption and implementation of mental health related evidence-based practices and other practices, heighten awareness, knowledge, and skills of the workforce, foster alliances and address training needs among diverse partners, and ensure availability and delivery of free, publicly available training in TA, like today. Our area of focus for our center is evidence-based practices for serious mental health issues, such as psychosis. However, like today, we provide training on a variety of topics. Our target workforce really is anyone whose work has the potential to improve outcomes for individuals. So folks that are experiencing or at risk of serious mental health issues. And these days, that seems like most folks. We offer free training, self-paced online courses, live webinars like today, and we record and post those in virtual learning communities. We also provide a monthly newsletter that might have been how you heard about today's event. We have a resource library we curate. We produce research and practice briefs and tip sheets, and we have other on-demand content. To find out more about our goals, training opportunities, and resources, you can visit our website, sign up for our newsletter, or follow us on social media. And so some of those links will be put in the chat at some point down the road. Now, a bit about language. It's always our intention to be mindful of using language that promotes recovery, diversity, and inclusivity. This demonstrates respect for a person's dignity and worth, promotes recovery-oriented practices that foster respect, strength, and hope. We want to next review some logistics. Large audience. Wow, it's almost doubled since I last looked. All attendees are muted. You're not appearing on video, but the presentation is being recorded, and the recording and slides will be made available in a few weeks. You'll receive an email from Zoom with a link for where we post those. It's called our archived webinars. You'll also receive an email within a couple of weeks on how to access a certificate of attendance. There's no formal CEUs, but usually this can help folks using that for that purpose. Now, for communicating, we have both chat and Q&A features. The chat is really helpful. You're having some tech issues. You just want to say hi. It's great to see where everybody's coming from. And you can chat your answer to a poll if something isn't working. However, for content-related questions for Ryan, we have the Q&A feature. So if you have any questions for them about the content, please type those in the Q&A box at any time, and I will be curating those for the end of the presentation. We'll get to as many questions as possible. If you put the content question into the chat, we can't copy it over, so it's just a quirk of Zoom. So we'll probably chat you back and ask if you can put it in there. So the other thing about this is we will generally try to answer all these questions, but we'll also be writing a Q&A and resource document. So if we don't get to a question, we can certainly ask Ryan if they don't mind answering after the webinar. Lastly, your feedback is very crucial to our work, so we would appreciate your response to a very short survey. Just takes a couple of minutes after the session. We'll share that in the chat box about 15 minutes before we end in case you have to run, and you'll also get an email reminder from Zoom. We are required by our funder to conduct this survey, and we know we just all love surveys, but I want to say we really look at your feedback. It's all confidential. We do not know who you are, but the presenters like Ryan and others, our training team, really helps us know, did you like today's content? Did you like how it was presented? Do we want to do more of it? And your participation helps keep this free training coming. So thank you in advance. Disclaimer, SAMHSA sponsors this work, but does not have any official position on this content. So there we go. Now, we're going to do a little bit of polls to get to know you. So I believe our team lead, Alexis, is putting the poll up on your screen. So there are two questions in this part. So the first one is, please pick an option that best describes your roles. We have 10 options that we can list, so I apologize. It may not have everything. And so clearly other is probably a close second for answers. So you feel free to type the answer in the chat box. That also helps us know who's in the audience as well as Ryan. The second question, if you need to scroll down to see, is what's your workplace setting? So lots of people answering. So we have over 200 people in the audience. We'll give you just a few. So I see a lot of behavioral health clinician or therapists, case managers, outreach workers. Let's see, other is still a close second, really, really high up there. So great. Thank you for sharing. And as far as roles, let's see, often behavioral health clinic, education setting. That's fantastic to have you here as well. And let's see, we're getting really close, 80+% participated. So everyone is going. We're gone for about a minute. I'm guessing let's go ahead and move on to the next question, if that's okay. Okay. And so here are the results. We have 34% in the case manager, behavioral health clinician. We have 17 case manager, education, and other, and a lot of the settings that were kind of going as we went along. So, all right, I think we're ready for the next poll. And you might have to X the box that's showing on your screen in case you want to close those results. I'm sorry, Alexis, if I was supposed to not close out the poll. Let's see. Okay, I'm going to launch it. Here we go. Oh, sorry, you already launched it. Yay. So Brian is interested in what are your years of experience working with transgender clients? Okay, less than a year, 1 to 2 years. Hopefully people are seeing this question. I am having issues, Alexis. Should I launch that? I will launch it. It is saying failed to start poll. So I apologize for that. We're having a little technical difficulty. But if you want to type into the chat, let's just go to that. That's very easy. So if it's less than a year, just type in how many years. That's probably easier. We won't have a bar graph, but that's okay. So just type into the chat how many years of experience you have working with transgender clients, and that will help Ryan and the rest of us know how that's going. All right. Well, we will keep going. And so I'm going to go ahead and introduce Ryan. And so we are, and please keep those answers coming in the chat. That's very helpful. So Ryan, we are very, very grateful to have you here today. Ryan Kim Tiêu is an associate clinical social worker. They were formerly the executive and mental health director at the Gender Health Center, a grassroots nonprofit staffed by and providing mental health, healthcare, and advocacy services for queer and transgender community members in Sacramento, California. In conjunction with professional expertise, Ryan incorporates their lived experience as a first-generation immigrant, queer, transgender, and young person of color into their praxis training and theories of change. So we're so grateful to have you, Ryan. Now we're going to have a little conversation. So let me make sure I can see that you're on. There you are. Hi. Sorry, all my screens were doing different things. So there you are. Thank you so much. And I just want to, again, thank you. I reached out to Ryan and where they used to work just as a cold call, essentially. And so I'm so grateful that you responded. And I'm so grateful that you are here with us today. So when we're talking about transgender issues, let's start with what path or key moment led you to working in the field of trans mental health?
Hi, everybody. So I feel like I've always known that I would be doing trans work no matter what profession I ended up in. And I knew this since I started navigating the health and mental health field for my own transition. I've had to educate my own providers since I was a teenager, and it made me realize the need for trans people to be leaders in the field.
Well, that's a very difficult journey, and to work it into your work. I think most of us in the field have some things, and it's really helpful to know that you've put all that experience to your field. How do you see issues of racial justice and health inequities intersecting with people who identify as transgender?
So race and gender are social constructions that evolve together, and trans people experience inequity, but trans people of color especially experience compounding systems of oppression. And when we are able to focus on queer and trans people of color, we're going to be able to improve the system, not just for those folks, but for everybody, and kind of raise the bar for all communities.
Mm-hmm. And this may be a naive question, but why do you think these disparities exist? And how did this come to be? These are big topics, these are big issues, but how did it come to be that there's such striking numbers of where trans folks, especially trans folks of color, are vulnerable, die at a higher rate, all those kinds of things that are just truly astonishing if you actually look into it?
Yeah, I mean, trans people experience a lot of discrimination. I think the fight is just to see trans people as people and argue that we deserve the same rights and care as everybody else. The healthcare system and mental health system also have a very long history of pathologizing transness, and making it so that transness has been seen as, an illness or disease, and we're moving away from that. But the foundations of that are still very present in our systems. You're muted, Christina.
Thank you. You've been doing this training for a while, and have lived experience. You've been in the field. You've trained as a social worker, clinician. What have you learned about providing this type of content training to providers? What lessons have you learned about doing this for as long as you have?
So I've been doing all of these trainings, and I've been training clinicians as well. And I think what's been interesting is that I've found that folks who consider themselves more seasoned tend to have a harder time with the material, as opposed to folks who consider themselves very new to the field. And I think it has to do with being able to embrace not knowing. My second piece of advice is really just to consider trans people, not just as clients. There are trans people in our families, or trans people in our community, learning about trans people to further trans liberation and not just be clinically competent in the population. And if you can operate from that framework, all the material will land with a little bit more conviction.
Well, and as a follow-up to that, do you see a change in, as you mentioned, people who are maybe newer to the field may have grown up with a different openness? I guess in my experience, I think that it's just more obvious to talk about these issues and to be encompassing. I mean, we have a long way to go in all areas, but do you see that as well? What's your take on these topics being more common to talk about than a really outlier?
Yeah, I think we're in this really interesting time where trans people and trans issues are coming into mainstream media. We see more trans actors, trans issues, and what brings me hope is that we're seeing stories that are outside of just like murder and death. We're seeing art, we're seeing artists, dancers, trans relationships, and for young people, especially that are on social media and watching TV, they're able to see a reality where being trans isn't just pain and misery. So we're seeing, more and more people go into trans work and really embrace who they are.
No, I agree. And, there's a lot of areas of our society, lots of room to grow, but at least the conversation is happening. I certainly see that in my own kids. They have a knowledge base that I never would have thought about at their age. So I maybe there's a little good sometimes in all the media they consume. Lastly, when folks learning about these issues, trying to put this all together, and they're trying to expand their experience, what is giving you hope right now in the field? What is giving you inspiration to stay positive?
What's giving me hope is seeing that trans people are going into these fields and becoming providers for our own community as well. And this is, there's whole conferences now where there is just trans providers. And that's something that, I don't think we could have ever imagined seeing maybe even like 5 or 10 years ago.
Well, that is hopeful. It's still messy, still not anywhere close to where we need to be, but I think it's a spiral. We're still learning, and we're hopefully grabbing more people as we go along. And I, again, really appreciate you taking the time, and thank you, Ryan, for this helpful discussion. At this point, I will let you take it from here. So thank you so much, and we'll talk with you in just a bit after you're done.
Cool. So let me turn on my screen share here. Okay. All right. Okay. All right. Good morning, everybody. Happy Wednesday. My name is Ryan. I use they, them pronouns, and I am a clinical social worker. I just finished my clinical licensing hours as well. I just need to take the big exam. So almost done with my LCSW here. And I'm sure folks are familiar with the term allyship, which is defined generally as being supportive to one another or being supportive to a person or a group. We're seeing this newer term more and more now called co-conspiratorship, which takes allyship a few steps further. Co-conspiratorship emphasizes action, specifically being able to weaponize your privileges to take on risks that people without those privileges cannot, to enact change. Some of our goals for today, I'm gonna say these are very, very ambitious goals. My hope with this webinar is to give y'all the tools to start and continue the conversation that is important for trans mental health. And we know that cultural humility is a lifelong endeavor, so you will not be transgender competent by the end of this training. It's really meant to be a springboard for y'all to jump into your own self-reflection, education, and co-conspiratorship with trans communities. What you will find today is that trans mental health is closely intertwined with the relationships, structures, and symptomology of the environment around us. So it makes sense to treat the individual by alleviating the symptoms of racism, transphobia, and discrimination that all impact the mental health of trans communities. I like to imagine this as if there was a DSM that diagnosed culture and society with its own, criteria, history, and interventions for all the isms that trans people, and especially trans people of color, have to endure every day. So we will start with the basics. We'll into some history that has led us up to this point. We'll get some co-conspirator tips. I'm going to go over transition-related care as well, and I do have a resource sheet at the end with a glossary, books, and other information. And there will be Q&A at the end. There is a ton of stuff to cover today, so I'm going to do my best here to save some time for Q&A. So thanks, folks, for filling out the pre-survey. We use those to really tailor the webinar to the audience. It's broken up into 3 areas: knowledge, skills, and attitudes. And I'm going to let y'all into a little behind the scenes here. There is a second section for trans attendees to share insight and their expertise. And this is really intended to center the voices of trans people, because I believe that everybody going to like a gender 101 type training should be able to gain something, but especially if you are a trans person. So here's the breakdown. We actually got about 75 responses. And it looks like most folks have a grasp on the basics of knowing the difference between gender and sex. And most folks have confidence with pronoun usage. But for the folks that don't, we will go over it briefly. We'll go over a history of gender as well, and the gender unicorn, but we won't focus on it since it sounds like folks are pretty confident. For the privilege and power questions, I saw a pretty decent level of awareness of white and cisgender privilege. I also saw education, ability, and heterosexual privilege kind of sprinkled in there as well. There are many other areas, like class, documentation, language. And in order to be a good co-conspirator, you have to have an awareness of your privileges in order to know where and how you can use them. Areas of improvement in the last section line up actually with what our trans attendees shared as well. We have intersectionality, and specifically with supporting Black trans people, as well as how and what disrupting systems of oppressions mean. I will say, though, that in the many times that I've conducted this pre-assessment, this is typically where I see folks struggle the most. So in summary, we have tons of stuff to go over. And we'll go ahead and start at the very beginning here. Some of this information might be familiar to folks, so we'll kind of go over it pretty quickly. So before I start, I usually ask folks to share about their first awareness of their gender. But since we're such a big group today, I'm going to ask folks to think just mentally about it. Think back to your first awareness of your gender. And everyone, no matter what your gender is, has an experience with gender. Trans people are often highlighted to speak on these experiences, but as providers, we should be able to answer the questions that we are asking. How old were you when you first realized the gender that you are? The gender binary is a systemic classification that assumes a role you will play based on your assigned sex at birth. That is to say, it essentially puts you in a box and restricts you to it. The two options are based on the markers male and female. In many cultures outside of this country, the gender binary does not actually exist. And there are cultures where trans people are considered sacred members of society. The idea of the binary is so deeply rooted in our society, however, that it causes much of the discrimination and mental turbulence experienced by transgender people. Transphobia itself is fueled by the dissonance caused by anything that exists outside the gender binary. Gender is the socially constructed characteristics and identities of women, men, trans, and non-binary people. The genders expressed inside this binary specify what men are supposed to look, speak, and be like, and conversely, what women are supposed to look, speak, and be like. This is greatly influenced by societal and cultural contexts. So when you think of the construction of your own gender, think of how you came to know how to perform it. This includes the internal sense of who you are, as opposed to the physical characteristics, genes, or hormones. And as of this morning, the Merriam-Webster dictionary describes biological sex as the structural and functional characteristics of a person that allow assignment as either male or female. Sex is determined by chromosomes, hormones, and external and internal genitalia. While this definition is updated, the dictionary only started separating gender from sex around 2011 in the US dictionary. And we do use sex assigned at birth instead of biological sex because it better describes what biological sex is trying to define. Many of y'all are already familiar with this, the gender unicorn. It's created in 2014, and it evolved from the genderbread man, which was created around 2010, 2011. And it was modified to be the unicorn to better portray the distinction between gender, sex assigned at birth, and sexuality, and also to be more body inclusive. I won't go over each section, but I will go over it myself, just as an example. So if I were to walk someone through this, I would start by explaining the overall structure of the unicorn. You might notice that gender identity, expression, sex assigned at birth, sexual and romantic attraction are all independent categories. You might also notice that male and female are not on opposite ends of the spectrum. In fact, somebody can identify all the way to the right as female and all the way to the right as male, if that is what their gender identity is. I'll use myself as an example. So starting from the top, my gender identity today is probably in the middle for other gender, to the left, a little bit to the left of that for male and man, and then even further to the left for female and woman. My gender expression is probably closer to the right on the masculine scale, closer to the left on the feminine scale. Sex assigned at birth is female. For sexual attraction, I would put myself closer to the right for women and other genders, and then on the left for men. And then for romantic attraction, I would put myself on the right for women and other genders, and then on the left for men as well. So contrary to popular belief, biological sex itself is not binary. And even on the spectrum of genitals, let's say people who have penises are a 1, and people who have vaginas are a 10. You can have genitals that are about a 5 or a 6. There are chromosomal variations like XXX or trisomy. Trisomy is also referred to being super female, which is very interesting considering people who have these kinds of chromosomes are considered intersex, as they can have a myriad of what are considered male secondary sex characteristics like Adam's apples and chest hair. There's also YYY, or any combinations of 1 to 3 X and Y chromosomes that can result in no phenotypic variation to vast and diverse phenotypic variation. Some people who are assigned male at birth may have extremely high estrogen levels, or vice versa, someone who's assigned female at birth might have an overproduction of testosterone. This is totally normal. People who vary with chromosomes, hormones, and genitals in this capacity are actually very common. And now that we've learned about the vastness of gender and biological sex, let's talk a little bit about pronouns. And it sounds like from the survey, most folks are pretty confident about being able to use gender-neutral pronouns. First and foremost, you should know what every single term or pronoun is used by queer and trans people. Trans people as well. We learn new words all the time. The first thing that you can do to ask if you're welcome to use a term is if you're hearing it for the first time is to ask, am I allowed to use that term? What does this term mean to you? How does this term impact your life? Those are all great clarifying questions. These are also great conversation starters into asking for pronouns. So when we ask for pronouns, the best thing to do first is to offer up your own. Hi, my name is so-and-so. My pronouns are they, them, theirs. What are yours? Something to note also is that pronouns can change. You can ask for pronouns as often as you need to, and it helps normalize the practice of asking for pronouns as well. A great way to do this is to incorporate it into your intake paperwork, put your pronouns on your badge, in your email signature, on your Zoom name. What do you do when you mess up? So cisgender people are a culprit of holding a trans person's attention by apologizing too much for misgendering someone. It's really important that you simply just say, excuse me, correct yourself, and move on. If you keep making mistakes, you can use an accountability jar where you pay an amount of money to a jar every time you misgender someone and then donate that jar to a trans organization of your choice. It's a great way to incentivize you and the people around you to do better. Gender is a racial construct. So Alok is a great resource for trans discourse, and I really recommend following them on Instagram specifically. Gender and sex are actually cultural and geographically specific ways of organizing people and society. Western gender categories were developed as a metric to demonize Black folks and civilize white folks. These are historically race-specific categories central to the dehumanization of Black people in early American history. The 19th century was around the time sex dualism became a dichotomy, which means that it became two distinct and opposite things. And scientists in that era argued that white people were superior because of their ability to display a visual difference between men and women, while Black, Indigenous, and other people of color were regarded as sex indistinguishable. And they considered a, quote, stronger contrast between man and woman to be indicative of higher development of race. Gender then was used to enforce ideas of civilized versus uncivilized, and these definitions were justifications for denying rights to not only Black and brown people, but also women. And gender was used as a tool to further racism. And this is why the deconstruction of the sex binary is critical to anti-racist work, and why anti-racist work is critical to the liberation of trans people. You can really get on my soapbox about this, but we are going to move on to transition-related care. In Stan Chang's book, A Clinician's Guide to Gender-Affirming Care, which I highly recommend and have listed in the resource guide as well, defines transition as a process in which a person shifts aspects of their gender expression, physical appearance, or social identity. It often involves moving away from sex assigned at birth to another gender. We don't say opposite gender because there are more than two genders that you can transition towards. It's often a lifelong process, and I've noticed a shift in the current language, and it's becoming more and more common for folks to say that we're transitioning to ourselves instead of transitioning to male or female. I like to describe transition like a buffet. People can choose the order and amount and the pathway of transition. There's no right or wrong way to go about this. Gender nonconformity is normal and natural. According to the Trevor Project's 2020 report on Black trans mental health, more than 1 in 4 Black LGBTQ youth use pronouns outside of he or she, and 1 in 3 Black LGBTQ youth identify as trans or non-binary. And speaking of Black trans young people, this is an excerpt from India Moore. She is a trans person and an actress in Pose. It's a Netflix series about the Black and brown ball scene set in 1980s New York. Highly recommend watching that if you haven't already. It's one of the few films where trans people are actually portrayed by trans actors. And she's speaking about the non-necessity of surgical modification. So surgery itself is not something that every trans person desires. It's usually expensive and often comes with many barriers to access. Many trans people believe that they need to have surgery to be the gender that they are, and that is simply not the case. The mental and medical health system have imposed these processes to access transition-related care in a way that positions the trans person as the subject and the provider as the gatekeeper. And in order to get most gender affirmation surgeries and even hormones, sometimes trans people are still currently required to see a mental health provider to get a mental health evaluation. And in these evaluations, the clinician's constructed responsibility is to determine if the individual's identity is, quote, stable and established, and if the individual is capable of making their own medical decisions. And when we think of cisgender people who get these surgeries, like hysterectomies, orchiectomies, mastectomies, mammoplasties, they do not require cisgender people to go through mental health evaluations to get the same surgeries. So I know that maybe in the next 10, 20, 30 years, I'm hoping that we'll see some of these restrictions lifted. Medical transition entails hormone therapy, gender affirmation surgery. There are some interventions that are reversible, some that are irreversible. For many young trans people, providers like to start with reversible interventions like hormone blockers, which usually come in injection form. Obviously, most surgeries are irreversible. Fertility preservation is covered by insurance in only 6 states, none of which are in the Northwest, unfortunately. But this includes sperm and egg preservation, as well as IVF and egg storage for a limited period of time. With testosterone and estrogen, there are some changes that are reversible and some that are not. This depends on the dose and the amount of time that you're on hormones. So there are 3 General types of need for mental health care related to transitioning. The exploration of gender identity is 1. Coming out and social transition is 2. And then general mental health issues is 3. Medical transition, like social and legal transition, are options to alleviate gender dysphoria. It is not a requirement to be transgender, however. We know that when folks who want to medically transition are able to medically transition, they report decreased anxiety, decreased social stress, better self-esteem, mood, and quality of life. There are many kinds of gender affirmation surgery. The UCSF Transgender Care Center is a great resource to educate yourself about them. In terms of languaging, anything that ends in ectomy is removal of. Anything that ends in plasty is creation of. We often refer to surgeries above the belt as top surgeries and below the belt as bottom surgeries. Therapy isn't a requirement to get hormones or surgery, but it can be helpful for processing change. And whenever we go through change, whether it's good or bad, it comes with growing pains, excitement, navigating conversations with the people around you, etc. Medical transition can sometimes lead to rifts in relationships. I've had many trans folks leave and lose relationships because a partner is no longer attracted to them or they aren't supportive of a medical transition. Social transition includes trying different names, pronouns, navigating public spaces differently. This is often the first step to transitioning that folks take, but this is also where having mental health support can be extremely helpful. This is where trans folks are figuring out how to navigate the world, their support networks and relationships. For cultural transitions, especially, it can include taking on the role of a son versus a daughter in your family, which is very common in Asian cultures. Social transition also includes the process of coming out, which is the process of self-disclosure of gender or sexual identity. National Coming Out Day, which started in 1988, was just 2 days ago, and is a pretty big part of queer and trans culture. I do like to use letting in instead of coming out, which is a more recent language shift that reclaims the power of disclosure back to the individual. Letting in recognizes that sharing parts of ourselves is an invitation to be a part of our lives. It's an act of trust and a demonstration of truth. It's not a one-time event, and it's not something that is owed to anybody. And being a part of a trans person's life, whether it's in a personal relationship or a professional relationship, really is a privilege that is not granted to many people. And I found that framework to be particularly helpful for helping parents of trans children in becoming co-conspirators as well. There are often experiences of fear and anxiety for the future of trans youth because we know the world is a scary place for trans people. But to teach a trans young person what it means to be loved and to be respected is a great way to prepare them for the world. Legal transition is a process of changing your name and gender marker in all of your documents. Transequality.org/documents has state-specific policies for changing these markers. There's also an X gender marker or a non-binary gender marker, and it is very new. But it is the first option outside of the gender binary for folks to have on their documentation. These are the states that currently allow folks to change their gender marker to X. This is also not a federally recognized change. So you can change like state documents, but you can't change federal documents like your passport. Though I think this will likely change pretty soon. But obviously, as you can see from the map, we have a ways to go. And it is very important to reflect gender diverse options on your forms. I'm going to show a video clip here of trans youth speaking on this. Let me, fingers crossed for the tag here. Share my screen again. Okay. I'm going to check the chat. If folks cannot hear this, put it in the chat.
Have you ever encountered problems filling out forms or like frustrations with having to like check certain boxes?
Yes. That male female box, that yes, because I want to mark female and legally I can't, and that irritates me. Or I might be on the phone with them and they may say, well, what is your gender? You know, and I have to tell them what my legal gender is, but that really frustrates me. It does.
Do other folks have similar experiences with that or different experiences that you would want to talk about?
They actually asked for your like preferred name, and I put it down and I was like, yeah, like they're gonna use it, and they didn't. And I was like, so what was the point of me putting it down if you're not gonna? So like, yeah, I get that there's the good intention, but like you're not gonna implement it, there's no point of putting it there.
If you could list off just 5 words or terms that you would like your healthcare providers to know or be comfortable with and like do some education on their own about, what would those words be?
Those would probably be cisgender, transgender, gender nonconforming, cis sexism, transphobia.
Cool. So just learning those things would be good.
Yeah, oh my goodness, please learn them.
Please learn them. Okay. Pull up my slides back up here. Right. So the pathologization of queerness started with the very first DSM-1, where we see sexual deviation being the umbrella term to define all folks who are not straight and not cisgender. The DSM-1 was released in the 1950s, which is not that long ago. And in the 1950s, Christine Jorgensen embarked on one of the first publicized medical transitions in history. She wasn't the first to medically transition, but one of the reasons that she gained worldwide attention was because she had been a US service member before and really embodied the epitome of masculinity in a post-World War II America. And the news would read, G.I. Joe to G.I. Jane, or ex-GI becomes blonde beauty. These are all popular ways that the media publicized her story. And you can see the binary systems of thinking that are still prevalent to today's discourse. And she actually had to go all the way to Europe to get gender-affirming care because the medical community in the US at the time was unwilling. And you can probably tell by the DSM-1 criteria that I will show in a moment here, is that the interventions that follow were probably neither gender-affirming or client-centered. And we had a long way to go, and we still have a long way to go. And the diagnosis of homosexuality wasn't removed until the DSM-2, which didn't come out until about 2 decades after the DSM-1. The medical community in the US didn't start shifting until the mid-1960s, about 15 years after Christine gained international attention. Needless to say, she demonstrated to a lot of trans people that medical transition was possible. And in fact, the Danish government that she accessed her care from banned gender-affirming procedures for non-citizens after the influx of trans people who wanted to follow in her footsteps. And while she paved the way for many trans people and incited transformation in the US medical community, she also inadvertently served as a template for the medicalization of trans people. And today we know that transitioning is like a buffet and gender is a spectrum with no set path. But Christine's narrative was that she felt like she was trans at a very young age. She was attracted to men and identified as heterosexual. And she was very conventionally feminine. And this is a very valid experience of transness, and many trans people share this story as well. But the medical community took this narrative and institutionalized a definition of trans people that was extremely rigid. This became a prescriptive model instead of a descriptive model. And later in the 1960s, when Johns Hopkins University opened the first gender identity clinic in this country, they created criteria for transness as people who, quote, felt like they were in the wrong body, were heterosexual, and knew at an early age. In fact, the criteria were so restrictive that a vast majority of trans people were turned away from those clinics. If you identified as trans and gay, you were turned away. If you were a trans woman and you liked wearing pants, you were turned away. If you didn't know at a young age, you were turned away as well. And the rigidity of these criteria really set the tone for trans care, and it still shows up today in our health and mental health systems. And let me go to the next slide here. So Marsha P Johnson is one of the most key, well-loved, and fundamental icons in trans history. She pretty much is single-handedly responsible for the creation of pride marches and has had an effect on all LGBT rights today. There are many, many articles on the Stonewall riots from the late 60s, but I'm going to focus on the time period because the growing politicalization of transness in the mental health field happened around the same time. Marsha herself survived numerous psychiatric hospitalizations resulting from discrimination and homelessness that she endured as a Black trans woman. But despite this, she had a profound way of putting others' needs before her own and helped bring the gay and queer liberation movement to the point where it also bled into the mental health field as well. We often do not realize the ways that we have been taught to think and even speak about trans people. And in order to be effective clinicians and co-conspirators, we have to be very intentional about the language we use and the way that we diagnose transness. And this is the diagnosis of sexual deviance that we see in the DSM-5. The remnants of this rigidity still exist today, even though we're making some progress. Trans stories in the media focus around usually medical transition or tragedy and centers white transness. Marsha P Johnson, who we mentioned in a previous slide, was about 7 or 8 years old when the DSM-5 came out. So transness was not quite a politicized identity yet. And in the end, of this diagnosis that we see a conflation of gender and sexuality. We also see that pedophilia was attached to transness as well, which is erroneous and a projection. And trans people, especially trans youth, are actually more likely to be victims of sexual violence. About 1 in 2 trans people experience sexual assault or intimate partner violence in their lifetime. But despite this, the medical and mental health fields have rarely afforded trans people autonomy and trust in our own expertise. The ways that this diagnostic model upholds in the system looks like the fact that trans people still need to go through a very rigid mental health evaluation to access gender-affirming care. And in this model, there's practically no room for non-binary or gender-fluid expression. So if you're trans, but you don't hate your body, there's not much you can do. You kind of have to just say what you need to say to get what you need. And the process of gender-affirming care still positions trans people as needing to define or to prove our transness in order to access care. One of the ways that we can combat this as clinicians is to understand gender as diverse and not deviant, and speak about the experience of gender and not its pathology. When trans people have to navigate a reality in which our humanity is constantly up for debate, depression and anxiety become completely appropriate responses to just existing. Now, the way that gender dysphoria is defined in the DSM-5 doesn't capture this nuance, though it is much better than where we came from, the DSM-1. Here is how the DSM-5 describes gender dysphoria. Is a marked incongruence between one's experienced gender and assigned gender of at least 6 months duration as manifested by 2 of the following. And there are 6 criteria, and I'm only going to show 3 here. So you can probably ascertain that this diagnosis is one that speaks to a narrative of self-loathing, unease, and dissatisfaction with your life. And these experiences are valid and really common in trans communities, but dysphoria is not something that every trans person experiences. It's also important to locate the movement and the source of dysphoria. There is a difference between distress with yourself and distress as a result of other people's distress with you, or what is often called societal dysphoria. This refers to the discrimination and violence that trans people experience. Another thing to notice is that gender is described using very binary language. Here we see a quote, strong desire to be of the other gender. The DSM-5 explicitly says that gender nonconformity is not in itself a mental disorder, but even then we still require a diagnosis to access gender affirming care. This version of the DSM also took the quote trans diagnosis out of the sexual disorders category and into a category of its own. Prior to it being called gender dysphoria, it was called gender identity disorder. And the shifts in the DSM have changed the way that trans people utilize mental health resources, especially when it comes to transitioning. For myself, I started my medical transition back in 2012. This was before the DSM-5 came out. So folks were still using the old criteria. This was around, this is a time where there was only one provider in all of Northern California doing trans surgeries. They were still required folks to be in therapy for at least 6 months. And folks also required that in order to legally change your name and gender, that you had to publish it in the newspaper. And that's no longer a requirement now, at least in California. Many trans people navigating mental health care still experience these barriers, however, due to providers using outdated standards of care. Remember that therapy is not a requirement, it is a recommendation. So follow the lead of your client and focus on the conversation on their goals related to their life direction, transition, and come from a place of curiosity. Language is always changing in our community, so mirror the language that your client uses. And in order to make sure that you're on the same page, you can ask, I've heard a lot of different definitions of this word. What does it mean to you? The international guidelines for transgender care, it's called the WPATH. We're on version 7. Use what's called an informed consent model, which is an approach that allows for the tailoring of interventions to the need of the individual receiving services. This is a model meant to empower the individual and give them the choice to move forward or not after a discussion about benefits, risks, and alternative care. It's also worth having a conversation about the benefits and risks associated with not moving forward with transition after a mental health assessment. With trans youth, especially, this is where we see the most impact. The WPATH standards of care have a section specifically on the risks of withholding medical treatment for trans youth. These risks include prolonging gender dysphoria, contributing to an increased risk of abuse and stigmatization and psychiatric stress. And it says in those standards of care that withholding puberty suppression and subsequent feminizing or masculinizing hormone therapy is not a neutral option for adolescents. Another way to combat this is using trauma-informed care. And this is kind of a buzzword right now, but what does it actually mean for trans mental health? Trauma is always part of the picture, and not in the ways that are defined by the DSM. We have PTSD and acute stress disorder that focus on post-trauma approaches. But when the trauma is constant, which is common for trans folks, we have to shift from focusing on diagnostic criteria to focusing on trauma that is impacting the expression and the experience of gender. And this can be exacerbated in cases, for example, where trans youth have to live in unsupportive households. This is something that we've been seeing more and more of since COVID and quarantining started, is that some of our trans youth are having to join Zoom from literally inside a closet, or joining on chat and not being able to join on camera or use their voice in their house. Trans people have taken this diagnosis of gender dysphoria and created what is called gender euphoria. Some things that we do to resist the imposed narrative of misery is to make room for conversations around gender dysphoria. These are behaviors, expressions, spaces, and situations that are affirming to one's gender expression, and that can look like having facial hair. It can look like wearing makeup. It can look like falling in love, being gendered correctly. Trans experiences are extremely multi-layered. What often induces dysphoria in trans people is not always the fact of identifying as trans itself, but rather the reaction to transness and gender variation from the world and the people around us. So gender euphoria can look as simple as being supported by the people around you. And experiencing gender euphoria, transitioning joy with blood in chosen families is a great mental health intervention. The concept of gender dysphoria challenges the idea that trans people only ever experience gender dysphoria, and that the story of being trans is one that is rooted in pain and suffering. Some of the ways to indicate allyship in your space are, putting up rainbow, trans flags, queer and trans media, having pronoun pins, provide an option for folks to use their chosen name, even if their legal name is not changed, and train all staff, not just clinicians, on how to use pronouns and language correctly, especially the folks at the front who greet and call the clients as they enter. So the 2015 National Trans Survey is one of the most comprehensive reviews of trans experiences in health and mental health care. It's available for free on the website, and it's something that is cited very, very often in trans Discord, and I highly recommend folks save a PDF from ustranssurvey.org. This survey found that many trans people, especially Black and brown trans people, have a really bad time accessing healthcare. I'm going to show another video here. See if this one works. And if the volume does not work, let me know.
A few years ago, I was diagnosed with polycystic ovary syndrome, and the doctors who treated me wanted to treat me as if I was a cisgendered woman who wanted to have kids, and didn't really take into account that that's not necessarily the way I identified or what I wanted.
Early on, after coming out, I had a negative experience, actually during my first pap smear. In the middle of it, started asking me questions about my sexuality, and then giving me quite a lecture about morals and about what was right and wrong to do with sex, and about letting down my parents, all in the middle of the procedure, which was a really sort of traumatic experience.
Just after I was received my positive diagnosis for HIV, I sought the services of a clinic in Melbourne. Basically, the assumption was made that I was just looking for a good night, and basically made the choice of having unprotected sex, when actually the case was I was sexually assaulted, and that's how I contracted HIV.
When I came out, I had a lot of issues with my family and them accepting that, which led to a few years being estranged with my mother in particular. And to rebuild that relationship, we had a few mediated sessions with a therapist. And those sessions became about how I'd left my mother in the dark and how I'd done wrong by her.
I ended up in an adult psychiatric ward where the doctors all refused to acknowledge me as trans and used the wrong pronouns, like, deliberately.
I've never had a good experience in healthcare.
It made me feel like I couldn't trust doctors. It made me feel like I had to very much bury who I am and just pretend to be normal, I guess.
This experience made me feel really vulnerable and not safe in my vulnerability. Yeah.
This experience made me feel dehumanized. It made me feel like I wasn't worth as much as other patients.
I've had one really good experience with a neurologist that I saw. She noticed that I'd ticked Mr. on the box, but my doctor had put the referral as female. And so she actually spoke to me sort of briefly about that and just asked what pronouns I'd prefer. And when she then had to write a letter again, she checked what I wanted to actually have on it. And that was fantastic.
I had a good experience with a GP who wasn't fazed in any way, you know, didn't blink, didn't act uncomfortable or awkward as soon as I mentioned my partner. And from the beginning, I felt that she understood that I was in a same-sex relationship, that it wasn't particularly relevant to the issue that I'd come there for, but if it did come up, it was something that could come up very easily and comfortably.
Come across a dental practice and they're really caring. They know I have HIV, and they're just very gentle and very considerate.
My message to healthcare providers would be to take the time to really learn about and become comfortable around issues relating to sexual diversity and gender diversity.
If it's out there and we know that people are actually investigating and finding the information and they actually understand, that shows that understanding of that, we can actually stop being so prejudiced ourselves and maybe try to find that help.
LGBTI people do go through more issues because we do have to deal with mental health at a higher rate than our heterosexual counterparts.
My message to healthcare providers would be just listen to your patients. If they say that they're trans or they prefer certain pronouns, that doesn't really affect you as a doctor. Just use the pronouns they ask.
It starts with just a dialogue, communicating and not expecting it to be listed on a piece of paper. It's very important that we have a communication that's one-to-one and that someone is actually listening to what we're saying.
That video gets me every time. Music and everything. Okay. So how are we doing on time? Am I supposed to stop at 35 or 45?
You know, thanks, Ryan. We are ending at 10:45 and agreed that video was just very powerful. We do have a couple of questions in the Q&A, so wanted to leave it to you because I certainly feel like we can get these answers from you, you know, via email and put on our resource document, but you tell us what would work for you.
Let me speed through the rest. That all I have left is the a tool for folks to use, and then we can go into Q&A. I'll try to save
Perfect.
At least 5 minutes for that. I watched that video so many times, and every time it gets me. Okay. So this is a tool that I like to use. It's called the Gender Minority Stress Resilience Measure. It's created based off of the minority stress model to focus more on trans experience. And it adds a layer of nuance by asserting that a hostile, transphobic, and homophobic culture is what results in negative mental health outcomes. And this model also asserts that these stressors are unique to folks with the corresponding identities. These are chronic stressors, and these are also institutional stressors. And this is a really great tool to thoroughly examine a trans person's experience of the world. Here is a breakdown of how it works. It looks at stress as distal and proximal. So distal factors look at external experiences like discrimination and stigma. It can also include experiences of racism, misgendering, assault. Proximal stressors really look at internalized messages of transphobia. So some examples of this that I've heard are, you know, I'm not normal, I don't know if I'm a real man, or even like I hate being trans, I hate my transness. Resilience factors can be group and individual. So group factors can be, you know, family acceptance, social support, community belonging. Individual factors can be cope and self-acceptance. And all of these, of course, lead to mental and physical health outcomes. There are 6 areas that this tool assesses for: discrimination, rejection, victimization, non-affirmation, internalized transphobia, and pride. And I will post a link to the tool that goes in depth into each of these areas. It's a pretty lengthy assessment at 6 pages. And all the answers are on a Likert scale. And you can score these by assigning numbers from 0 to 5 to the scale and seeing which sections score higher than others. But it is super helpful in incorporating the lived experience of your client in a non-pathologizing way, which is a much more comprehensive look at trans mental health. Let me drop the link here. Oh, thanks. All right, so that is the end. We talked about the basics: gender versus sex, legal transition. We talked a little bit about Marsha and Christine, both pivotal figures in trans activism and trans care, and left y'all with some diagnoses and tools. And there is a link to the resource guide. It is a Google Doc, and you can save and you can copy that to your own Google Drive or save it as a PDF. And I'm gonna end the presentation by saying, you are all authority figures in the lives of many people. This means that you have a rare opportunity to advocate for familial acceptance, to teach others what I've showed you today, and to talk to people about supporting us and leading by example and educating others as much as possible about trans disparities, trans joy, and trans lived experience. And starting this dialogue is life-saving for many people, and I hope that you all feel a little bit more confident about being able to start these conversations. And we can move into Q&A.
Great. Well, thank you so much. I learned a ton, and I have strived to try to be educated, and it's that video is powerful. The ideas of things not just focusing on the negative experience of being trans, I think is just really, really empowering. It's such a great point, and the letting in, just fantastic. Thank you so much for this material. So our first question was, what are recommended gender categories to include on forms or applications for youth? Maybe I have an overall response to that too.
Yeah, I don't know if there are youth specific genders. I like to have a fill in the blank for folks to put the gender that they identify. I know that sometimes creates some administrative burden for if you're trying to take that information and assess it statistically. I can share maybe in a more thorough Q&A document the genders that we put on gender health centers forms.
That'd be great.
I can do that.
Yeah, we can. So just for folks later on, we will have we had an event page for this event, and then we have a product page when we have the video ready, and we include the slides, and we include anything that someone like Ryan shares with us. So we can absolutely put that on there and make sure people know about it. How do you feel? This is a complex question. How do you feel about the diagnosis of gender dysphoria for trans folks? As a cisgender therapist, I don't feel comfortable diagnosing someone with gender dysphoria because there's nothing wrong with expressing and being your true self.
Yeah, I mean, I'm hoping that at some point we'll move away from even needing to diagnose trans people entirely. There are countries in the world that don't use a diagnosis model, and trans people just need to go to the doctor and ask for what they need. It is better than what we've had before, certainly. But we have to diagnose people now because this is the system that we're forced to work with. For billing, for Medi-Cal insurance, you have to diagnose usually in the first or second session in order to bill insurance. And I've been lucky at Gender Health Center. We do not bill insurance, so we all of my training has been in a model that is not dependent on diagnoses or pathology. So we just have to keep advocating for the folks that are doing this work, moving away from the diagnosis model for trans care.
Yeah. Another question. Well, we have more questions and we're almost out of time. So let me see what I can get. Some folks put some into the chat that if you put a question into the chat, if you can put it into the Q&A, because now I'm worried I'm going to miss your question. Okay, so I think someone said, can you recommend any resources for supporting adolescents who are exploring gender identity? Now, again, you can email that to us and we'll put it on the product page. So if you want to go into it now, but we have other things that people have asked. So is that something you could just email us and we can include, or do you have, okay, that sounds great. So thank you for that question. And then do you have recommendations for working through internalized transphobia in therapy or counseling with trans clients?
Yeah, I mean, it's really tough because I think a lot of trans folks, some of us only see all the bad things about being trans. You know, the first time I heard about trans people was from watching, I think it was Boys Don't Cry. I was like, all right, so if I come out, this is what's going to happen. Great. And, you know, a question that I like to ask is, you know, what do you like about being trans? What do you love about being trans? Another thing I like to do is have trans people talk to other trans people and really see, you know, what trans success looks like and what transness looks like outside of that narrative of pain and misery.
Mm-hmm. Mm-hmm. Okay. Is there an amended way to diagnose? Is there an amended way to diagnose such as depression, anxiety related to gender dysphoria? I'm not totally sure if I'm getting the question exactly, but does that, maybe they're asking, is there a way to amend a diagnosis? That might be the question.
Yeah, I don't think there is currently. Sorry, the gardener is here.
Oh, that's no problem.
Ideally there would be, you know, that we can diagnose things that way, but I don't think as our system exists now, I don't think it is possible.
Okay. And then just to let folks know, the resource document will be a link to a document that's posted on our website. So you shouldn't have to download it. You could just view it, is how we normally have those things. So just to answer that question. And then lastly, is the GMSR a standalone tool? Does it get scored? And are there suggestions for follow-up based on the answers?
So it can be used as a standalone tool. It really is meant to be a conversation starter, and you can score it if you want to, and having the answers be like 0, 1, 2, 3, 4, 5. And yeah, I mean, there's a lot of follow-up based on like if someone scores higher or lower in a different section. I think if you take a look at the tool, the questions are really thorough, and the assessment looks at, you know, external and internal factors. So it's a good opportunity to not just talk about the things that are happening inside, but also like what resources do you have access to right now? Who in your family or who in your support network is there for you, and etc.
Yeah. Okay, well, thank you so much, Ryan. I just want to make sure I can resume our slideshow and then share my screen. So your feedback is so important. If you could please do the brief survey, it really helps us, Ryan, everyone, our evaluation team, really just make sure that we can tell how you enjoyed or didn't enjoy this topic, if we want to hear more. And just a reminder, you'll see that in an email as well from Zoom. And then something coming up this Friday is Safe, Sane, and Stable in Turbulent Times. And this is a presenter we've had a number of times in the spring from Rebecca Demerol, Trauma Integration Programs, really, really helpful content always. And if you want to know more, find out about us, register and see the links in the chat for how to find our website and sign up for the newsletter. And again, just really want to thank you, Ryan, for all your contributions to the field, to our learning every time. It's fantastic, and we look forward to working with you more, hopefully in the future.
Well, thanks for having me.
All right. Thank you, everyone. Take care. I assume all of us learned a lot today, so go forth and keep doing better, as you said. Thank you, everybody.